introductory webinar. Susan Maua. I work for NACADA in the Department of Capacity, Public Education, and Capacity Development. So why are we here? We want to just let you know, first of all, that we are working towards professionalizing the field of prevention, treatment, and even recovery. And the more we engage with people, the more people trainings, what trainings are there. So, and then there are those who have also been asking, what do we do with regard to credentialing? Because some of you on this call are already credentialed. We also use the term certification. So it is loosely used so that at the end of the training, you have a certificate. Somebody says, I am certified. So that means you have a certificate after the training, but that is not the same as certification. So we are also going to talk about that. We will also look to be credentialed, and basically that is what we are going to have in this training, in this webinar. And I want to right away give Rita to start us off with the first part, and then later on I will talk about which trainings are there in this coming year, and also for those who want to be credentialed, what are the requirements and who is it that is ready to do that in this financial year. So over to you, Rita. Please use the Q&A to, if you have any questions, use the Q&A so that we'll be able to address any questions if there are. Rita, where are you? Yes, please unmute and also share your.
Okay. Good morning, everyone. Good morning.
And go ahead.
Okay, thank you very much, Madam Susan. So thank you everyone for joining this webinar. My name is Rita Hayo. I work in the Department of Public Education, Directorate of Public Education and Advocacy in the training department, and I'm so glad to be here. Thank you for sparing time to join us for this webinar, where we want to talk about drug use prevention. And on this, we are looking at, where is my getting stuck? So this is basically our agenda of the day. We will be looking at the national guidelines on drug use prevention. We will also look at the code of practice for prevention practitioners in our country. We will also look at the national alcohol and drug use prevention system. And also, how do we then become prevention or treatment practitioners for those of us who are not yet there? And also the requirements for credentialing. So many people have been asking about credentialing and confusing the same with the certificates that NACADA give, and we'll also open a session for questions and answers. So allow me to start us off with where we have been as NACADA, as the lead agency, and as a country. For those of you who have walked with us the journey, you have seen before we just used to talk about drug abuse in general. where we could just raise awareness on the dangers that are associated with use of drugs and all these other substances. And more so, we have been in the business of using the scaring tactics, where we would tell you drugs will kill you, don't do drugs, don't take alcohol, you will die of it. And mostly we could connect with very scaring pictures, so that once you see these, then you are feeling, I should not use alcohol, I should not use substances, and then that's all. And also we had, when you go around even institutions, some people still have these tags in specific areas where they just say no to drugs. And then we're asking ourselves, how do you just say no to drugs? And also, all this that is presented here is common in our buildings, in our environments. You will meet people who have put tags of drugs and they cross in there. So that is where NACADA has been. We have even been using real life people who have recovered from substance use, mostly in our presentations. When we are having a forum, we invite them to come and speak to the people, to tell them, yes, I was like this, I used to use substances, I used to use alcohol, but now look where I am. So this is basically the journey that NACADA has been traveling. And so we also had events, like we come to a place, we talk, we sensitize, and that's it. You know, we talk to the young people, we talk to the adults, we mix them and we gather them together. But now we have moved, we have transitioned as an institution. And that is where we are now talking about prevention. And from where we have traveled, we were unsure, we were puzzled, we were confused, we were lost, we were baffled. So in all these, any other person could just stand up and speak. There was no like uniformity, you know, you end up even confusing people more. And when you confuse people, when you lose people, then that is even another risk factor that can make these people go back to use substances. So basically, this is where we have been. And now we have put our house in order so that we don't look lost, we don't look unclear. And that is the journey we have traveled so far. And traveling that journey, NACADA has also, sorry for that, traveling that journey, we have invested a lot in prevention. And the primary objective of this prevention is basically targeting or to help the young people, because we want to get this young mind when it is still fresh, we nurture it, we mold it. And therefore, that is what we are saying. As an institution, the primary objective of prevention is to avoid totally. If someone has not started using, how do we help them not to start using? How do we talk to these people? And this is where we target mostly the parents, where we look at the guardians, so that when these children are still developing at the family level, what information do we impart in them so that they develop or they grow knowing what are these substances that people are talking about and what are the effects? And we are also saying we want to delay the beginning or the starting point of use of substances, like for teenagers. How about you all are aware of the debate that is going around the country about having revised the age from 18 to 21, delaying initiation. We are talking about delaying the starting period of use of substances so that we allow this child or this person's brain to develop fully in the mid-20s. And we are talking also about how do we avert the development of substance use disorders. If this person has started, how do we help this person not to get into the problematic kind of drinking whereby they are not productive enough, or they are becoming a baggage to the family, to the society at large. So we are looking at three major things: avoiding, delaying initiation, and averting development of substance use disorders. And so our country, through the lead agency, has made great strides towards implementing evidence-based prevention strategies. When you're talking about evidence-based strategies, we are talking about those interventions where we have conducted enough research and we know how research informs action. So everything we are talking about as an institution, even when you hear us talking about revising the age from 18 to 21, this is based on research. And so we have developed the National Guidelines on Alcohol and Drug Use Prevention, which were launched in the year 2021. We have also developed a code of practice for alcohol and drug use prevention practitioners in Kenya. And this is so because we want people to speak from a point of information. We don't want to look confused. We don't want to look puzzled. We want to do things from a point of information. So basically, this is how the National Guidelines on Drug Use Prevention that were launched in 2021 look like. This is the cover page. And this document is also available on the NACADA website. So I will take you through some of the key areas of the National Prevention Guidelines. And of course, our goal in the prevention guidelines is to establish a minimum requirement that is used in conducting effective alcohol and drug use prevention programs. And these programs are targeted in various settings. We have the school, we have a family, we have workplace, and we have communities and media. And when you look at this, the way they are arranged is how we transition in our developmental ages. Like when we are growing up, you start with the family, then you go to school, then workplace, then communities. So we have interventions in all those settings. So the objective of the prevention guidelines is basically to advise on best practice in prevention interventions. People have been saying, or rather, people do prevention, yes, but we didn't have something, the basis or the foundation of how this prevention is supposed to be done. So the objective number one is to advise on the best practice. We want you to do the right thing, do in the right order so that it is quite effective. It is achieving the desired goal of the behavior change. Objective number two is to ensure professionalism in planning and implementation. We want people to have order in what they're doing so that you don't just wake up today and you say, me as Rita, I'm thinking I can be a prevention person. Just because maybe you have someone in the family who has been suffering from issues of substance use. And objective number three, we are saying we also want to provide minimum requirements for service providers. What is expected of you in the prevention guidelines? What are the do's and the don'ts when you are a prevention practitioner, so that you also don't end up doing harm to the people that you're serving? Instead of giving service, you are the one who is doing harm. Objective number four is to foster development of national prevention system. So out of this, we have also developed a national prevention system, which I will also take you through, where prevention practitioners are supposed to be reporting the work that they do biannually, that is twice a year. And this prevention guideline is covering every other stakeholder that is involved in development and implementation of alcohol and drug use prevention programs in our country. So looking at the prevention guidelines, we have standards, and we have 8 standards. So the first standard talks about the setting. The setting is basically where you are conducting your prevention work. And we have primary, we have the family. From family, you go to school. Even the pictures that are projected on your screen shows it's depicting a family, and then the school, and then from school you go to the workplace, and then we have the rules, laws, and regulations in the community. And when you are looking at the primary setting, we have the microenvironment and macro. So when you look at the family, then you go to school, and then you go to the workplace, those are microenvironments, the small environments where you can have say, you can come up with your regulations, and they work for you. And when it gets to now rules, laws, and regulations, we are looking at the macro, the larger environment of our country. And then the standard number 2, the prevention program should be age appropriate. So this is where, when you are targeting specific group, the needs with age-specific messages. For instance, when you're talking about children of various ages, you cannot put the adolescents together with the adults, because the challenges in these various age groups are different. And we insist on these age groups because when we are looking at the developmental mileage of children, if a goal is missed at a specific developmental age, it is going to affect the subsequent developmental ages. So you need to be very, very specific that whatever age group you're targeting, the information you're giving to them or the interventions you're putting in place for that particular age group is specific to them. So that is where we are also reminded, especially those of us who do preventions in school, we are reminded the way we lump the Form 1s, Form 2, Form 3, Form 4s together, that is very wrong, because a Form 1 is just joining. The Form 3s and 4s are on their exit plan. They know quite a lot that is different from this person who has just joined and is still being taken through orientation. So always remember, standard number 2, you have to be very age specific or age appropriate. And standard number 3, prevention practitioners should be guided by professional ethics in development and implementation of the programs. And we'll be looking at the code of ethics because we are talking about the competencies. Are you competent enough to provide that service? Are you providing or talking about what is required? The integrity of this person, the consent. We have seen what consent can do. We have this issue that happened at the treatment facility and a patient just lost her life. We don't know really what transpired, but we are saying, do you also ask for the patient's consent, or we are the kind of people who force people into doing things that they are not willing? So we look at standard number 4, where we are talking about ensuring that there is inclusivity and non-discrimination. So promote active participation of the community members in multiple settings, irrespective of level of vulnerabilities. Remember, there are various different vulnerabilities. So don't get into a community and start saying, because these ones have been drinking so much, so they are not part of this prevention program because watakusumbua. No, it has to be inclusive and non-discrimination. If there are people who are physically challenged, they also are vulnerable. How about you include them in your prevention, or rather in your programming, so that they also don't feel left out? And then when we are talking about standard number 5 is on the risk and protective factors. And this is where we are talking about enhancing protective factors. Protective factors are those factors that will help, or rather make these people not to use substances. And on the reverse, we are saying they reduce the risk factors. Risk factors are those factors that predispose you into substance use. So how about we work on enhancing protective factors as we reduce some of the risk factors in the community? We can talk of risk factors like the risk of availability and accessibility. That has been a problem. It is, you see substances being sold everywhere. So even if you are a recovering alcoholic that you are thinking that now I'm stopping, once you are passing there on your way to work, you are tempted. So how about reducing those risk factors in the community? And then on standard number 6, you are looking at the prevention program delivery. All these prevention programs have a way that they're supposed to be delivered. Remember, we are using manuals that are already put in place in a way that whatever you are carrying out. There's a specific way you're doing it in terms of the timings, in terms of the content, how long, how big is it? So it has to be, you adhere to that. So long-term, it's normally long-term and with repeated interventions that reinforce prevention goal rather than a single event. And that is why when I started, we said we used to be confused, puzzled. We didn't know what we were doing, where we could just walk in and we talk to you and we are thinking there'll be a behavioral change. With these prevention standards, we are talking about a long-term repeated intervention. Remember, you keep repeating monitoring and evaluation, looking for what did not work and what is working as you keep changing or doing it the right way. When you look at standard number 7, then it is talking about monitoring and evaluation component. You monitor for effectiveness and efficiency. And we are told programs should have indicators. What is the problem and what is the expected outcome? Some outcomes are short-term, some are long-term. So what do you want to see at the end? And so you keep monitoring in between. As you are putting your intervention in place, you keep monitoring stage by stage, and eventually you will evaluate the program and see vis-a-vis the cost that you put in. Has it been effective enough? Has there been any positives that you're seeing from the program? And then on standard number 8 is where we are talking about having effective prevention programs that are comprehensive services, socio-culturally relevant, and well-trained staff. Remember, our society is has different kind of cultures. So wherever you are that you are putting this intervention program, make sure you are able to learn the culture of the people. Because if you don't learn the culture of the people, for sure, at some point you'll just get resistance. So understand the culture, flow with it, have well-trained staff who also are understanding what they are doing, that they do not end up doing harm. So those are the 8 standards in prevention. And looking at this now, this is how the prevention that we are talking about looks like. On the left-hand side, we have the settings of the prevention. And on the top, we have the developmental stages, all the way from prenatal up to adulthood. So these are the interventions that you're supposed to put in place. And when you look at family, we have the prenatal, infancy, and visitation. That is an intervention. And this is, the prenatal is targeting the pregnant mothers, those who are expectant. What are you supposed to do to protect yourself and even the child who is in the womb? We also have interventions for pregnant women with substance abuse disorders, because there are also those expectant mothers who are already having the challenge of use. And we are saying there are also interventions, and the stars depict the strength of the effectiveness. So you see here we have 1 star and 2 stars, not very good, but somehow it works. And then from prenatal and a family, we go to middle childhood and early childhood. For this one, we are talking about providing parenting skills. And when you look at the colors here, the green, we have green, we have yellow, and we have red. So green normally is for a universal team. Green is universal. Universal, we are talking about the entire group, the users and non-users. And when this yellowish, it's kind of yellow, we are talking about the selective. The selective, these mothers who are using, they're already at risk. And the red one here will be for the indicated, those who have already initiated. So we after family, we go to school. And then we find at early childhood, we have 4 stars, which means it is good, it is effective. Early childhood education. And we see this being provided in school. It is good, and it is for the early childhood children in school. And then we move to middle childhood, and we are finding personal and social skills. We have classroom management skills, policies to keep children in school. They also work. And so when we hear our government talking about, oh, they will not be providing food in school, or they will not be doing ABCD, We feel sorry because these are some of the things that keep children in school. Like if you say a feeding program, you will see the families that are really struggling with issues of poverty. Children look forward to going to school because they know there's a meal they will find in school. How about classroom management? We also have some children who are a problem in the school. How do you talk to the teacher so that they know how to manage all these children who are getting into middle childhood levels? Because some of them, they just need some skills imparted in them and they'll know how to settle so that they're not a problem to other children. And then you look at addressing individual vulnerabilities at adolescence. And we know how adolescence affect very many people in the society. So you see, it is red. This is where some of them would have already initiated substances. And again, you look at community. You see the community, the green one is from prenatal up to adulthood. So when you're talking about community-based multi-component initiatives, this is a collection of so many, a collection of a wide range of interventions that we put in place. We are talking about interventions within the family, interventions in school. We are talking about interventions in the community, a multi-component kind of initiatives. And some of these, we are talking about the media campaigns, mentoring and entertainment venues. How do we teach the entertainment clubs where people go? How do they handle those who are already intoxicated and they do not need to take more? And how about the media campaigns? How do they also help us in just passing the message across? And then at the workplace, you find the workplace prevention interventions that we put in place. We have had policies at the workplace. We have just had having trainings and sensitizations. And then at the health sector, we are talking about brief interventions with the 4 stars, which means it's very effective. How do we just have those talks that are meant to change behavior so that someone feels, oh, anyway, what I'm doing is not right. I just need to stop drinking. So prevention also has other issues that are requiring further research. Of course, we have had school activities. So we are saying the after school activities, sports and other structured leisure time activities need further research. Why is it so? Remember, most of these school activities are not structured. And how long do they even take? Are they a one-off thing? Who is even delivering this, or who is taking care? The coaches that come to do these kind of sports and all that. We do not know what they have taken. There's no, that measure like, is this person sober? Is this person using? The people who even come to sell stuff during these kind of activities outside or within that area is also a challenge. And then the issue of monitoring and evaluation of prevention programs, preventing the non-medical use of prescription drugs. Remember, prescription drugs has been a challenge. If you look at our statistics, you'll see, especially the survey that was conducted in the primary and secondary school, the 2016 and 2018 survey, you'll see prescription drugs is a challenge. But the issue of monitoring and evaluation. Monitoring, remember, prevention programs take quite a long time. And monitoring and evaluation is quite a very expensive affair. So it has been a challenge that people put interventions in place, but monitoring and evaluating to the end to see if it has achieved the desired goal, it has been a challenge, and therefore it requires further research. Interventions and policies targeting children and youth, particularly at risk. When you look at children and youth, you find that the environment that they are in, they get to face quite a number of challenges at different developmental stages. So it has also been a challenge that it requires further research to bring out what are the right interventions to put in place. And then policies targeting families. Families are dynamic. How do you even get to put them together, all these mothers or all these fathers, or even the mothers and the children together? What do you do with dysfunctional families? What do you do? We have single mother families, we have the nuclear families, extended families, you know, all those kind of families. That has been a challenge there because of the dynamism of families, and also the issue of media exposure, influence of media exposure, and also the issue of using celebrities in our country is an area that require further research, because we have seen even in our society, when you ask your child, some of them will mention some of these media celebrities. Oh, I want to be like so-and-so, I want to be like so-and-so. But when you look at it further, then again, you start hearing cases of the person that your child was looking up to is the person who is most affected with these substances. So that is the prevention guidelines. In detail, the document is available on our website. We now have to look at the code of practice for alcohol and drug use prevention practitioners in Kenya. You put your questions in chat or any other thing that you have, and then we will take them up once I finish the presentation. Sorry. So let us look at the code of practice. That is how the cover looks. You see, there's that clock, and we are saying, what are we achieving as we go on with our prevention work? So this code of practice for alcohol and drug use prevention practitioners in Kenya describes the core values, the shared responsibilities, the commitments and obligations within which alcohol and drug use prevention practitioners should work. So if you call yourself a practitioner in prevention, then this is where you should be. You start looking here as I present, and you'll be able to know, have I achieved this, or where am I, and what do I require? So of course it has 3 objectives. The first one being to regulate the conduct of prevention practitioners. And this is so to weed out those people who have been purporting to be doing prevention, but they do not have the required competencies, skills, and the knowledge. And then the objective number 2, we need to harmonize content, structure, and delivery of prevention interventions and policies, so that it is not different. Like if Rita here at HQ is speaking to people, is teaching people or conducting a training, and my colleague in Narok or my colleague in Kisumu is also conducting, there is some uniformity, so that we remove the confusion that people will be wondering, I attended a training in Nairobi HQ, but it was not presented like this. The content was not like this. The number of days covered were not like this. So we need that uniformity. And then objective number 3 is to provide minimum requirements for service providers. So we'll be looking at what are the papers that are relevant to you calling yourself a prevention practitioner. And of course, its purpose is for information, education, and guidance, developing or updating quality criteria and performance appraisals. So let us continue. So the rationale, of course, is on standardizing knowledge and practice of the interventions for a better achievement of the objective. Because if we do not standardize the knowledge and the practice, then we will not be able to achieve our objectives. And looking at these evidence-based interventions and practice, this will ease the issues of harmonizing, monitoring and evaluation, correction, redirecting, strengthening efforts within the prevention framework. And when you're talking about this, of course, we are talking about issues of regulations. What are the regulations, the policies, and the standards, the rules, requirements, and laws that we are supposed to comply with? As a prevention practitioner, you should be privy or aware of all these laws, regulations, and standards that are in place. You should also be aware to tell us about the research that the lead agency has conducted, and any other person who has conducted research on issues to do with ADA to be at your fingertips, so that when you are also speaking, you're able to tie to what is happening or what the research is talking about. Because remember, we are talking about evidence-based. So this code of practice applies to policy and decision makers, remember, to better understand what prevention practitioners are aiming to achieve. And this is through their work. Also, the frontline workers, to guide those who work directly with the target population in drug prevention, and also to tailor activities to the needs and ensure delivery is of high quality, and refer individuals to specialist services where required. I'm just curious, I don't know how many of the people represented here, those of you who have your own CBOs, how many of you take time even to take your frontline people just through what is happening within your small establishment? Because sometimes you will not be there and a visitor comes who needs help. Are they even capacity built to know what to do, even just the first aids to handle, either if it is a treatment facility or if it is a prevention person? Do they have that knowledge? And also in training, we are talking about standardizing drug prevention training, and it will serve as a manual outlining all aspects of high quality drug prevention work. So you'll be seeing what is required of you. And also we are talking about supervision. It will serve as a reference to identify the training needs. Where are you and what do you need to do? Like we talk about certification. We will give you the certification, and a higher power will give you the accreditation, and that will be taken through after this. It will also highlight key areas and identify existing gaps that the practitioners will need to pay attention to. And of course, these will have regular follow-up, support, and mentorship. Also for consultancy, evaluation, academic research, it will provide a comprehensive checklist and reference framework. We already have prevention and treatment practitioners database with us. And that is how I was able to reach quite a number of you, because we are also not just sitting back and saying we are training you. We are looking at how many of you have reached at what level and how many of you still need to be brought on board and be mentored. And then, of course, we are talking about resource mobilization. It may be applicable for making funding decisions when you write out your proposals, and may be used to conduct formal self-assessment as a basis for accreditation. So when you're talking about the knowledge, competencies, and tasks, remember this is a code of practice, and each other profession, they have theirs. So even us, why not prevention, you know? So these are the minimum requirements for prevention practitioners, coordinators, and prevention specialists. 1, you need bachelor degree or diploma in health science or social sciences. And just in the chat, maybe you put the degrees that you get in the social sciences. Those of you who have done, please put in the chat for the benefit of those who are looking forward to getting this. And then diploma in addiction counseling. That is especially for the treatment people, and training in universal prevention curriculum, the UPC, for coordinators and specialists. And here we are talking about, there is the introduction to prevention science, there is physiology and pharmacology, there is introduction to UPC series for implementers, which is the core, and shall be a basic. This shall be a basic for all. The UPC core shall be a basic for all, so that you find like the physiology and pharmacology and introduction to prevention science is covered therein. We are also talking about specialty in areas for school, for family, for workplace, media, community, for those who are working in specific setting. And for your information, you cannot be in all these settings unless you're a quack, because all these settings, they have their manuals, their trainings that you're supposed to undertake. But you can be in 2, but not more than 3. So you also need specialty in those settings and knowledge of the current issues of substance use disorders, including the DSM-5 classification, the tool, the manual that is used for the mental disorders, for classification of the mental disorders. And then knowledge on national guidelines on alcohol and drug use prevention, 2021, the one that I have just taken you through, and other relevant working documents. So you will need all that. So these are some of the practitioners' principles for ethical conduct. Remember, each profession has its principles. And we are talking about principles for ethical conduct that express recognition of responsibility to the public, to service recipients, and to colleagues within and outside of the prevention field. So they are the general kind of ethics that you are supposed to apply, the general ones. And then there are those that are now for the service provision, when you are conducting the service. And you as a professional, what is your professional competence? Of course, the issues of consent, if you are dealing with the children, or if you are helping somebody, have they consented, have they agreed, or you are doing this by force, you are forcing the service. And then the issues of confidentiality, how do you treat information of a patient? How do you relate with your clients? Remember, they have come to you because they know you're a professional, you are able to assist. So what is the relationship you're having? Are you the kind of a practitioner who will get into personal relationships? Maybe you're soliciting funds, maybe you're soliciting other things. And then, of course, professional supervision and professional standards. All these are outlined in the code of practice in detail. Then we look at the National Alcohol and Drug Use Prevention System. In short, we call it NADAPS. And this is where now, as a professional, you are expected to be reporting twice a year. And this document, the way it is, it directs you, or it guides you on how to report. So it's not rocket science that you'll say you're not able to. The tool is on our website. So, of course, the rationale why we developed this tool is because there has been no concrete information about how or for whom and where prevention is conducted in the country. So we need to know, if you are doing it, where are you? Because we are also getting details of your location and everything, your address, so that once in a while we also have impromptu visits to see what you're doing, if you are doing the right thing or not. And then the need for collaboration and coherence among organizations that are involved, and also to bring together the various sectors to be involved in the delivery of systematic prevention interventions and policies. Also to provide for clearly defined roles and coordination to ensure effectiveness in planning, delivery, monitoring, and evaluation of the various components. So this is like a collection of every other thing that every prevention person is doing. So that even if you walked in and you wanted to know who else is doing this, we'll be able to open for you and tell you, you are doing with so-and-so in this location, this is what they are providing to children, this is what they are providing to pregnant women, and so on and so forth. So it is like, it's collecting information that is for use to all of us. And the aim is to collect, analyze, and use data to inform prevention policies and strategies. We go there, we look at it, and it helps us in analysis and informing what next prevention strategies that you want to put in place. And its goal is to provide a strategic framework for planning, delivery, monitoring, evaluation, and reporting of prevention efforts in schools, families, in all those settings that we have mentioned. Its objective is to coordinate national and county prevention efforts to provide a structured reporting mechanism. Before we didn't have, so now we have a structured reporting mechanism, in that the tool is provided and everyone reports. Whatever you are reporting into, the other person is also reporting into, so it is structured. It's not like you'll just bring a report that you have just thought out and written on your own. You are guided. And then it also provides the national audience with information for policy and decision-making regarding alcohol and drug use prevention related services and programs. We report what you have provided. And then it also strengthens cooperation with various arms of government, the non-state, those who are not in government, and then the scientific community also can use it on their research purposes in promoting evidence-based programs. Also for data collection and analysis and interpretation. And for your information, we do reporting to national and international levels. This is used to inform on the data or on the happening of within the country, especially when you're reporting on International Days Against Drugs. All this data is compiled together and it informs now the next level of action. And then it serves as repository for evidence. We store as evidence informed prevention programs, and also organize national and annual meetings for sharing best practice, where we normally have a national prevention week. The last one was very successful, which was conducted here in Nairobi at All Saints, and we are hoping this new financial year will also have another very successful one. So this is basically what the NADAPS, or the prevention reporting system, looks like. It constitutes both government and non-state actors are allowed to report in. And then on matters, research and quality assurance, it translates scientific findings and new paradigms, new ways of doing things, the effective interventions and principles of effectiveness into practice. And the interventions, of course, all prevention programs in all the settings. And we are talking about from front line service providers to decision makers, professionals and implementers. And we are targeting decision makers, professionals from the drug field, the general public drawn from all the settings. So what are the roles and responsibilities of stakeholders in the National Alcohol and Drug Prevention System? So under civil societies and faith-based organizations, we are talking about implementing, their role is to implement prevention policies and programs, to participate in regular prevention system meetings when called out, to utilize prevention systems to inform evidence-based policy and programs, that is by reporting, and then coordinate data collection and sharing prevention data with NACADA. And then NACADA, as the lead agency, we coordinate capacity build for the target audience. We receive the data, collect and analyze and share the information with different stakeholders. We convene regular prevention meetings, like the National Prevention Week, and even this one. And then we also submit national, regional, and international prevention reports. We regularly update the prevention system stakeholders database so that we also guide accordingly. There are some people who reporting is still a challenge. And then we also utilize the prevention system to inform evidence-based national policy and programs. So these are some of more of the stakeholders. Like we also have the Ministry of Education and Teacher Service Commission. They're also supposed to be reporting in the NADAPS, the private sector businesses, ministries responsible for youth and children's services, ministries, county governments, and department agency, and all these are supposed to be reporting therein. So this is a biannual reporting template, and it is available on our website. If you go to NACADA website, and what we do, under Public Education and Advocacy Directorate, you will find the prevention system reporting. So you just click there and it will be prompting you as you respond accordingly. And the reporting is twice a year. So from January to June, you report in July. So, and again now from June to December, you report in January. So you report twice. So when you are talking about prevention science, we are talking about practice and research. And in practice and research, we see when we conduct research, of course, we are identifying the risk factors and protective factors. So we are looking at how do we enhance the protective factors that are mentioned therein, and how do we reduce the risk factors so that at the end of it, that research will inform practice. And that is when we say we are conducting prevention science. And that is why even the policy, the ADA policy that is attracting a lot of debate, it is because research was conducted. And the more research we conduct, the more practice we do. And you see, we have conducted research in public sectors. We have conducted research in primary, secondary schools. We have conducted research nationally. We have conducted research in university schools. And when you look at all this, then you'll see why there is need to review all those clauses in the National Alcohol and the Mutudho law, the famous Mutudho law. So when you're talking about prevention, we look at the environment. And in the environment, we have two: the macro, which is the larger environment, and the micro environment. This, whatever is projected on your screen, is called etiology model. And when you're looking at the etiology model, under micro environments, we have all these: the issues of poverty, the issues of social environment, where we live, the physical environment, how we socialize, how we live with our families, our capabilities. And when you're looking at the micro now, we narrow down to family, the peers, the people we relate with, the schools, and the workplace. So these micro and macro interact, the two levels interact. And that is where they come to meet the personal characteristics of who we are. And who we are, again, is informed by the genetics, where our lineage of development, the temperament that we host inside us, the physiology, how our bodies are reacting, you know, and the beliefs and attitudes, this shape, all this will shape the beliefs, attitudes, and behavior. So it might tell you now you will be a partaker, or now you will not be a partaker. The only thing that saves us is the personal characteristics. What kind of a person are you in the society? Are you able to be swayed by all these interaction of the macro and micro level environments, or are you strong enough to fight it? All these, the genes that are in you, the temperaments that are in you, that you do not use substances. So that is my presentation on the guidelines, the code of practice, and the reporting system. I don't know whether there are questions in the chat.
Thank you, Rita. I don't see any questions on that, but
yes,
I can see Agnes has raised her hand, but okay. I would want us to keep the questions until I make the presentation, so that we have all the questions together. Okay. And please use the Q&A. Please use the Q&A for questions, not on the chat. And then I would also, as I move to the next one, I would also want to advise. I can see there are many people, or a group of people, who are asking questions on medications and so on. Please note that this forum is not to educate on medications, yeah, on medications. Even somebody's asking, are nurses supposed to be prescribing and so on? So that would be a totally different forum. So please let the questions be addressing prevention and treatment, and what are some of the causes, because some of the questions that you are asking are better even addressed during the specific trainings. So thank you, Rita. And so now I would want to take you through the questions. I've already seen some people asking about trainings and so on. And that is what I would want to address next, so that then we can, you can ask your questions after. But please note, you can use the Q&A so that they are addressed, just like some people asked, okay, so what trainings are there and so on. So now I want to take you through, this is a compendium for trainings that are available. Once we've gone through this, it is also going to be posted on the website. So it means if you want more information on it, it will be there in writing. And of course, even this recording will be shared on the website and also on our YouTube channel so that you can follow. So as you've seen, we have two arms. There is the prevention side, and then there is the treatment side. So what are the causes? So those who have been asking the causes that are available. Now, this is the time when your questions are being answered. So we start with the prevention. So in prevention, there is a basic course that you need to undertake, and it is the one Universal to Prevention Curriculum Series for Implementers. You can see it can be done online. It can also be done in person. And this course is the foundation. So if you have not undertaken the foundational course, then it is going to be very difficult for you to do the subsequent courses. I know previously some of you may have done family-based when we were offering, but you had not done the Universal Prevention foundational course. So this is the foundational course. If you have not undertaken it and you are in prevention, then it is time that you prioritize this. And you can see it can be done by those who implement prevention activities, whether it is in school, it is in the workplace, it is in the community, it's all those settings that Rita has mentioned. So it can be done by health workers, by counselors, by people in county governments, by educators. So it is, as I said, it's a foundational. As you can see, we have both online and in person. Now, the next course, as you heard, that the first setting is the family. So this is the family-based prevention interventions. Again, this one is a little shorter. You can see it has 7 courses. But when it is online, it means that it is staggered. You come to class two times in a week, but then it goes for 3 weeks or 6 weeks, or depending on the length of the course, because you can see some are shorter, some are longer. Yeah. So again, it can be done by people who are implementing. So now that means that if you work with families, then this would be the course for you, if you have done the foundational course. Because when we come to the next group of courses, some of the details that are done in the foundational course is not covered because it's already assumed that it has been done. So that means that this, if you are working with families, whether it is in the CBOs or in the faith-based organizations, wherever it is that you work with families, it can also be done by health workers, by counselors, by church leaders. And that is why I'm saying the family health practitioners and even parents. Yeah. So this is a course that can be undertaken by a wide range of people. All right. Now we come to the next one, which is the school-based. So now this is for people who work in the school setting. It can either be done in person or also online. And we appreciate that many people would prefer to have online because it is 1, cheaper, and 2, you can be reached wherever you are. Just like in this particular forum, people are drawn from all over the country. So it means that it can actually be, you will be able to access the trainings, even particularly if it is online. Now you can see the teachers, the counselor, the school administrators, and unless you also work in a school setting, as I know some groups already work in school settings like SCAD, like Brooklos. Yeah, those are some of the people who, this would be a course for you. I've also seen some people in this forum that are also in the workplaces. So this is now for those in the workplace settings. It could be somebody in the public sector or even the private sector institution. So it means that this course is tailored towards the challenges that are in the workplaces. Yeah. Then the other course that we have is media. So for those who work in media, yeah, it could be media practitioners or those who use media as a way of reaching out. This again is the course for you. You can see it is a short course, even given that it is 20 hours. Then again, we recommend in person. We recommend in person because of the kind of people who get targeted. Now, the other course that is available here is called environmental-based prevention interventions. Now, this has to do with interventions and policies. Yeah. So when we talk about the tobacco policies, the alcohol policies, and the misuse, illegal trafficking, and so on, you can see it can be done in person or even online. And so the faith-based organizations, the community-based organizations, if you are in county government or you are even a prevention practitioner who wants to have a better understanding of the policies and how we can implement them, then this is the course for you after doing the foundational course. Now, the next is the community-based prevention implementation systems. Sometimes just by the name alone, somebody says, I want that one. But you need to have done the foundational course. So you can see again, the people who work in the communities, the faith-based organizations, the community-based organizations, even people in county governments, this is also a course that would be appropriate. Now, from there, now we have what we call specialized courses. And the first one is on the workplace-based prevention interventions for managers and supervisors. This is a level 2 kind of training. As you can see, it is also 20 hours because managers and supervisors usually don't have a lot of time before they are called for one thing or the other. And so you can see that it specifically targets managers and supervisors. It would be better if an organization or any institution, private or public, have already undergone the basic workplace, because a lot of details is done in the workplace. Now, this one is only targeting supervisors. So it means that you need to have the policy in place to address the substance use issues at the workplace. Then the second specialized course is called the Student Welfare Staff Training course. Again, it is also a short course. It is targeting people who work with students or who are in charge of students at colleges and universities. So that means the dean of students, the student counselors, the janitors, the university health staff, and even implementers of programs that are targeting colleges and universities. So those are the people who need or whom this course is suitable for. Then we have the peer educators training for workplaces. This also, as you can see, is another short course, and it targets the workers that are drawn from different cadres. There are some institutions that already have peer educators. So those are the people we build their capacity here. So you can see this is also a level 2 kind of training. It means that you must be having a policy that is already addressing the issues in your workplace. And therefore, you also want to build capacity of peer educators so that they can enhance what you are doing in the workplace. The next specialized course is the community work groups. And some of you on this webinar have already done this course because we have been training and then establishing what we call community work groups to be able to address the challenges of alcohol and substance abuse at the community level, that is grassroots. So that is why you can see the people who are targeted are community-based organizations, the faith-based organizations, the county governments, because counties are the next unit at which a lot of work is also being done. Even the school community representatives, all these become part of what is the community work group. So this is also a specialized training. Now, the other training that we have that is specialized is the life skills training. It is an in-person training, and it targets teachers and implementers of school-based programs. Or unless you are also somebody who implements programs with children, so that you are trained as an implementer. So it means you are trained and then you should be able to take children through life skills. So we are talking about the actual life skills program, and you can see it's a practical skills. Like now, when schools closed like this, yeah, and if you are trained in that area, it means you can actually you can actually be able to take learners, yeah, in this program. So ordinarily it is implemented in schools, but it can also be implemented by community and even faith-based organizations who have such kind of programs within their community organization or within the church system. Yeah, because you know that there are some faith-based organizations that when schools close, they have education programs or such kind of forum for students. So that is what the life skills training is about. So it's a specialized course. Now so now I'm done with the prevention. There are a lot more courses on prevention, but that is what I would like to share at this point. Now let's move to the other continuum, because we start, remember Rita said we have universal where most people are non-users, then you have selective, the ones who are most at risk for substance use. Then we move to indicated, which is the people who have already started using drugs but are not dependent. But the moment they become dependent, then they cross over now to the treatment side. So it's a whole continuum. So what is the foundational course that you need to undertake? That is the basic level universal treatment curriculum. And we have restructured it so that it is a hybrid course. Hybrid means you are doing both online and then later you transit to a physical training. And some of the people who are in this webinar again have gone through this training. Some of you may have gone through the training when we used to call it phase 1, phase 2, phase 3. And there's a team in Mombasa who I know are on this call that have organized for an in-person training. So that means that they are going to do it in the 5 phases. In the 3 phases, but that means that it takes longer. Now, the new way in which we want to conduct this training is to have 15 online sessions that can tell you how many weeks that is going to be. Then you have an in-person that then targets the very areas that require a lot of practical sessions. So that is the basic course that you need to do. It can be done by counselors, the clinicians, the psychologists, social workers. So basically, those are people who are in the addiction treatment area. Yeah. Now, the next are specialized courses. So the catch is you can only do specialized courses if you have done the basic level. For a long time, we have just been doing the basic level. So now in this year, we want to start on the specialized courses. And you can see the first one is working with families with substance use disorders. So that is a new course that we anticipate, depending on how many of you would actually want to do that. And when I finish, I will conduct some poll so that we see which are the preferred courses, because that is what will determine which course is going to be done. Now, for those in recovery and those who do recovery support, we now have a specialized course called Delivering Recovery Support Services, or the PEER. It's in person or can be online. And you can see it is specifically targeting those in the recovery support. So if you do that kind of work, that is the course for you. Yeah. And then we have another one that is targeting those who work with women. It is called WISE. And this is Women's Intervention for Substance Exposure, which is a comprehensive care for substance use disorders. And again, you can see now this is 11 weeks. It's an intensive course. And by the way, all these courses are intensive. Intensive 11 weeks. And again, treatment implementers, it can be done by psychiatrists, psychologists, but it is better if you work with women. Yeah, that is when now, after the training, then you can utilize what you have learned. You can see something else that is very close to the one for recovery support is also recovery management and relapse prevention. So this is also targeting recovery support professionals. Like I said, the training will be done depending on which one is of preference to the people who are here. Now, the other one is treating adolescents with substance use disorders. Yeah. This is also a course that will be done online. I haven't indicated the hours, but it will be done online depending on if we have a quorum for that. And remember, for these courses, other than the recovery support, you must have done the basic level UTC. So what are the training options? I've already mentioned whether it is online or in person. And then there is the third option. Which one? If it is online, then the cost is going to be 5,000 shillings for whether the course is going to be 6 weeks or 3 weeks or 4 weeks, depending on which course it is. For in-person, in-person, it is at the cost of 30,000. That is if we organize the training and then you are plugging in. However, if you are so many within your organization, you can organize for an in-house. So it means that you are taking care of the costs of conferencing. Yeah, you're taking care of the cost of conferencing, and also you need to have at least a minimum of 20 participants so that it also makes economic sense for you. So you can see that is subject to discussion depending on the location where you intend to do it. For example, if you're doing it in Nairobi and you are organizing it in-house, it means that it's going to be a lot more cheaper than if you decide that you are coming from Nairobi, but it's an in-house, but you want to do it in Mombasa or Machakos or wherever. So that is why I'm saying it depends. So I hope you have taken note of the various courses that are available. We are moving from just the basic to the advanced or specialized courses. The other thing, before we do the poll, that I would like to talk about is what we call credentialing. Yes, credentialing, because we have noticed that after somebody has gone through any of the trainings that we've talked about, then somebody says, I am certified. Yeah. So what are the requirements? Because the examinations or the credentialing that eventually you get is the ICAP, all right? So what is credentialing or certification? It is actually a formal process that verifies the qualification, education, training, and experience of professionals to ensure that they meet the standards necessary to provide safe and effective programs in either prevention or treatment or recovery, right? So that is what this credentialing means. So I'm going to take you through what are the requirements for each of these, because now we have prevention. So if you are a certified professional in prevention, then it means you need to be trained in the science of substance use and abuse prevention. What we have, the trainings that I've just described. You needed to have met the minimum standards for education and training and supervised experience, and then there is an exam that you pass. You will notice that if you conclude our trainings, the trainings that we conduct, eventually we give you a certificate, a certificate of participation. But here it means that you needed to have passed an ICAP prevention exam. So it's not just like after you have been trained, then we give you a certificate. But for you to be an ICAP prevention, you needed to have passed the exam. We had the first exams done in Kenya last year, and almost everybody who participated passed the exam. So that is the requirement for prevention. So what are the requirements? You needed 2 years full-time or 3,000 hours of working experience. So it means that for you to be an ICAP prevention, these are the conditions that you need to meet. You need to also have a bachelor's degree in a relevant field. You needed to have completed 150 hours of supervised practical experience, meaning that you are actually doing prevention work. You needed to have done a minimum of 120 documented hours of prevention, education, and training. And these hours you get from the trainings. I hope you saw I was saying this one is 33 hours, this one is so many hours, and this one is so many hours. Those are the documented hours. So moving forward, when you do a training, then you are going to find it is also indicating the number of hours. So that is the purpose. So that for every training you do, you will always see that is indicated. Additionally, there are also webinars that are conducted, including the ones that are offered under ISAP. If you are a member of ISAP, they will always share when there are webinars. So just note that those webinars also give you some of the hours, because you get a certificate, and for those webinars, it's usually 1.5 hours. And then in addition, they also would like an additional 6 hours on physiology and pharmacology, and also 6 hours on ethics. Remember, ethics is a key issue even in prevention. So that is for ICAP 1. So so far what we have is ICAP 1 prevention. Even I am ICAP 1 prevention, because prevention is relatively new, particularly when it comes to the issues of credentialing. So if you move to the next level of prevention 2, then you can see the number of hours that you needed to have had, the completed hours of supervised training. Those who are carrying up their hands, I will give you time to, we will respond to questions. So let me just finish this and then you will be able to raise your hands. But remember, you can also use the Q&A for questions. Supervised practical experience, documented hours, and again, in addition, physiology and pharmacology and also ethics training, all right? Now let's look at those who are in treatment, yeah? A certified professional in treatment needs to be trained in the science of substance use disorder treatment, and you need to meet the minimum standards for education, training, and also supervised experience, and you needed to have passed the appropriate ICAM treatment level exam. Now, ICAM, for treatment, it's been around for a while. Yeah, it's been around for a while. And so you can see for those who are in treatment now, we even have ICAP 4. So for ICAP 1, you require 1 year supervised experience and 120 hours of education training. And those of you who, for example, did the UTC that we offered last time in the last financial year, you already had like 80 hours of education or training. Then ICAP 2, you need 2 years experience and 240 hours of education and training. ICAP 3, 5 years supervised experience and 500 hours. And ICAP 4, you need to have a master's degree or higher in substance use disorders, addiction, or related counseling subjects with 5 years supervised experience and 500 hours of education and training. So that is for those who are doing treatment. Now remember that more in the finer details of what else you require, I will give you the link where you can do this. Then we have the people in recovery. Because now we also have the recovery support. You need to be trained in the basics of the best practice of supporting those in recovery of addiction. And what are the requirements? You also require 100 contact hours of education and training. So that means that if you have done, for example, UTC, and then you come and do the recovery trainings that I've mentioned, you will be able to get those contact hours. And you can see here, the focus is also on, you needed to also have 6 contact hours on HIV/AIDS and ethics training. So that means 1 year full-time of supervised experience in the SUD recovery support related field. And you needed also to have passed the ICAP exams. So these are international. These are international exams. These are not, that is why I'm saying there's a difference between getting a certificate. After you have completed training, we will give you a certificate. Yeah, we'll give you a certificate. But now for you to talk about credentialing, then this is where you have the exams, and you can see it is $50 for prevention. For treatment, it's $100. For recovery support, it is $50. Now, for some of us who have had our prevention certificate, for example, for a while, it is time to renew, and they also reduced the charges. So those are the charges for those who have. So that means that whatever level of ICAP you have, it is valid for 3 years. And then continuing education is required, and you can always go to this website here, icuddr.org, so that you get more details on what you actually require to become the finer details, because what I've given is an overview. So now, because I've said, what training would you require? Yeah. So I want to conduct a poll, and I hope you will be able to, if you are in prevention, the first question is on prevention. The second one is on specialized courses. The third one is on treatment. And the fourth one is if you have previously done these courses, but you would be interested in ICAP exams, then you will also select that. So you should be able to see it, and therefore you should also be able to do it. So I hope you can see it. So please respond. I can see people responding, so that means each one of you should be able to see. What for treatment? Sijaona hata moja. So it is the choices that will help us, will help to inform what trainings we are going to offer in this financial year. Wengine wanasema they can't see. Sasa sijui wewe unatumia nini? Because I can see people are responding. But so far, 76, 34. Please don't be quiet so that later, this is actually addressing the issues of people who have been asking which trainings are available. I am interested in this training. So now we are taking census of which training we are going to offer. But remember that if you have not done the basic course, so those, there are those ones who say, I can't see, I can't see. Don't carry up your hand right now. Right now, we are taking the poll. So just respond to the poll. Then, once we are done, there will be a chance to ask questions. From your end, you should be able to see question 1 up to 4. And remember that if you are in ICAP treatment, then you know you can't start with 4. It means you must have been level 3 to want to move to 4 and so on. The questionnaire is not being sent. The questionnaire is, you should be able to see it on your screen. It is not being put on the chat or something like that. So the first question is, if in prevention, what is your next preferred training? Yeah, let me help those who can't see because of whatever gadget they are using. Question number 1 is asking, which is your preferred training if you are in prevention? If you have never done the basic course, then it means you should be saying UPC core. But if you have done those, we have family, we have school, we have workplace, we have environment. Yes, those are the courses that we propose. Specialized courses, remember, it depends on whether you are in the workplace, you are in the universities or colleges, or you are dealing with, you are either a health educator in churches or in schools. That is when you should select the life skills. If you are in treatment, we have the basic level course. Yeah. I can see those who are saying, please display. It's already displayed. And you should be able to scroll down. If you can see it, you should be able to scroll down. I am reading for those who are not able to see, because that's the only way I can help you. If you are in treatment, you need to have done the basic course. If you have not done the basic course, then that is what you should be choosing. Yeah. The specialized courses. Yeah. The specialized courses. The specialized courses in treatment, the condition is you needed to have done the UTC, unless you are in recovery management and relapse prevention. Yeah. So for treatment, we have working with families, recovery, treating adolescents with substance use disorders. And the question number 4 is asking if you have done, if you are interested in ICAP exams. It means you have already gone through the training. You've gone through the training, kuna certificate, kile imebaki is credentialing. Yeah. So either you are in prevention or you are in treatment. Yeah. So I want to, coming in the next, I'm giving 2 more minutes, and then we shall close the poll. There are 240 people on this call, but so far only 79% have participated. 80% have participated. Yeah. So if you have a challenge, that I was reading for those who have a challenge, so that you put it in the chat, and we are going to, I hope Rita is able to collect those ones. Because after this, it is going to be very unfortunate if you are asking us, which trainings are you offering? Which training are you offering? It is UPC core, not SCORE. Core means the foundational, right? So remember that if you want to do family, school, workplace environment, you needed to have done UPC core. It is written there, the requirement is UPC core. Yeah. For treatment, you can see it is treating adolescents with SUDs and working with the families with SUDs. The basic requirement is basic UTC. But for those in recovery management and relapse prevention, you need to be working in that area. All right, so I am ending soon. Yeah. In 30 seconds, I will be ending the poll so that we leave the remaining of the time for questions. 82% have responded. And the poll is closed. So the poll is closed. Yeah.
Hello.
I have dropped off, so just answer the question.
Okay. Okay, hello. Can you hear me? Hello? Hello? Oh, you can't talk. What is not happening that you can't talk? I'm trying to see how I can enable you to talk. Are you back, Madam Susan?
Yes, I'm back.
Okay, thank you.
I don't know. Okay, so I don't know if you can see my scores. I can see a number of people are interested in doing ICAP prevention. All right. Okay, all right. So let's see. I can see people can see. So these are the findings, and you can see there are a group of people who would want to do UPC core. There is family, there is school. Given number also on workplace and also on environment. But remember, you need to have the basic course. So it means that when we make the call for that, we will also compare with what is on the chart, because we are appreciating that there are some people who are not able to do, to be able to do that. Now, for the specialized courses, I can see many people would want to do life skills. And then, like I said, for managers and supervisors, that is for workplaces. So we are going to, when we call, we will compare this also with what is on the chart, and then that is when we will be able to make conclusive. I can see many people would want to do recovery management and the relapse prevention. Some would want to do basic level, others wako hapo katikati. So again, we will make that comparison. I can see 2 people want to do 4, 3, some would want to do 5, 2, and so on. So even that we will use and see how we can have that conversation with the ICU DDR for those who know about what this is about. Okay. So again, we are going to compare with what we have on the chart, so that because I can see people are sending in what they would want to do, probably because they were not able to. But remember, for you to do ICAP 4, you must have been at ICAP 3. All right, so this is the time. Let me see if I can enable people to carry up their hands. So please carry up your Wambisa, go ahead. Your hand is up. So Wambisa, if you are there, Samson. Unmute and go ahead. Okay, Alice. Alice.
Sorry, Madam Susan, it was by mistake. Sorry, I'm sorry for that.
All right. All right. Alice Wairimu Murithi. Unmute and speak. I hope yours was also not by mistake. Please speak. Alice, there's no sound from your end. Okay, so do we have any questions? Because this is the point at which, Alice, we cannot hear anything, and therefore I have muted you. And please, if you have carried up your hand and you want to speak, once I allow you, please do so. Kainga Stephen, go ahead. Kainga Stephen, I have allowed you to talk.
Yes, I was asking what is the timeline if like someone is in treatment for all these treatment now? What is the timeline that one would have gone through all these processes to the final requirement to be like accredited, like you talked about credentials. So like now, what is the timeline that is expected for all this process?
Well, it depends. It depends on which training, because remember there is a requirement in terms of education and training, and then also in terms of practice. Yeah. So it depends on which particular area that you want to focus on. Yes. So it varies, like I was presenting, it varies on which particular one, because they are different, whether you are doing prevention or you are doing recovery support or you are doing the treatment. Yes.
Okay.
All right.
Thank you very
Albert,
much.
Albert.
Yeah, good morning, Ms. Susan. Thank you for the opportunity. Yeah, I have two questions. One, thank you very much for this presentation. It's been very informative, and it has, I think, answered a lot of questions. Two things. One is how we follow from here. I was wondering whether you will have like a portal where we can sign up to the different things, or even be able to be kept informed of the developments as you proceed, because these are many different trainings that you're launching, and just to know what is available when, etc. That's one question. And the other question is, I am aware, because I'm a practitioner in the field and have been so for some time, that you are partnering, many of these credentialing things are in partnership with foreign bodies, and those foreign bodies already have, they've given us access to them directly. So just wondering, in the future, how is NACADA going to interface, like we say the ICU, DDR, who are doing the ICAP things, etc. How are you going to interface? I'm having a problem right now in being unable to update my credentials for some technical reasons. And I would imagine that if I could go through NACADA, it might simplify things. So two questions. Thank you.
All right. So thank you, Albert. Indeed, we you see, Nairobi has been a center for those exams. Yeah. And these are some of the conversations that we had with the ICU DDRLS. But remember, you can directly engage with them. Yeah. But what we are doing is we are actually addressing the gaps that have been there because people write to us and ask, so what should I do with this? What are the requirements and so on? And that is why we were having this sensitization with regard to credentialing. And of course, the person in charge even asked, would you want us to do a webinar on this? Yeah. So if it comes to probably having that webinar, then that is something that we can organize with the ICODDR, but particularly not just for the people we trained, because when we had an opportunity to actually have the exams in this country last year, and we actually announced this to every other service provider, because it's not just NACADA that offers this, even other service providers, so that if they can announce and let people know that there is an opportunity to actually have that examination happening in the country. Yes, so that is one. Number two, the trainings available, remember that is why we are doing the polls, and I've said we already have your contact. That is how we were able to reach you in the first place. So it means that depending on which trainings are actually the preferred, then we are going to have a poster, yeah, and actually announce, yeah, and actually announce this training, so that there is a call for actually signing up for the training. So that is what we are going to do, so that as much as possible, those who sign up, and then you then can be part of the training. All right. So thank you, Eric Gishovi. Please, I have allowed you to talk. Unmute and speak. Eric Gishovi. Go ahead. If Eric cannot find his voice, then let me allow Peter Mule. I'm going to go according to how I can see them.
Good morning, Peter Mule.
Okay. Okay, Peter, go ahead.
Hello.
Hello, go ahead.
I have two questions. One is about changing, raising the age of drinking from 18 to 21 years. I wonder why not 24 years? Because we know up to 24 years is when the brain matures, the malleability of the brain is now fully developed. At least that will help the young people to have developed and to not to be easily influenced by the alcohol. The second one is there's the new drug which is in the field, that is Mukoka, which has not been there, but according to our laws, is not part of the drugs. It's not a illegal drug, and we can see from experience how many people, especially the young people, are involved in it. What is NACADA doing to ensure? Because we have seen it has even more harm than the cat, the miraa. What is it being done? What is NACADA doing, at least to ensure it is classified as some of the drugs and the preventive measures are put in place? Thank you.
All right, thank you, Peter. I would want to shelve answering your question for now, because I want to address the issues that are relevant to this webinar that has to do with the train. It's not that I don't have the answers, but that, forms part of what is usually in the sensitization. But what we are addressing now is the questions that have to do with the sensitization we've just had regarding standards, regarding trainings available, and so on. All right. So all those are usually covered as part of training. All right, let me go to Betha. Betha, I've allowed you to speak. Betha, can you unmute? Okay, all right.
Hello?
Yes, I can hear you. Just speak louder.
Yes, I just had a concern or a question.
Mhm.
Yeah, I wanted to ask maybe for those who are already trained on alcohol and drug use addiction counseling, then have also gotten the opportunity to do the introduction to prevention science, which was equally geared towards accreditation by the International Center for Credentialing and Education of Addiction Professionals. So it means like for our case, if you wanted to do now the workplace, you can just go straight to workplace. And can that
Yes.
now help us go to the next level of accreditation? Because ICC 1 we already did, and now if we were to move, then it's gonna be 2.
So do you already have the credential?
Yes, for ICC 1 I did.
Okay.
ICCE 1,
All right.
yes.
Yes. So that is why the question is, would you like to be, yeah? Would you like to move to the next level? Because again,
Yes.
people are at different levels. Yes. So
Okay.
if you meet the minimum requirements, why not?
Okay,
Yes.
that's fine. I'll make a follow-up.
All right. So the other person that I can see the hand is up is Gitonga Muhuriri.
I'm sorry. No,
I have allowed you to talk.
Yeah, for me, I wanted to ask if I've not done ICP 1 and but I have a diploma in counseling, and I'm also having experience in personal experience in addiction, and I'm in recovery for a long time. If invited to schools, is it allowed for me to share my experience, strength, and hope?
The answer is no. The answer is no, because even by saying experience works better if you are talking to people who are struggling to get out of addiction, so that you are showing them that it is actually possible, but not in schools where you share your story. By the way, they can't relate with that story. That is what science is actually showing. Yes. So what you require is the skill, the trainings. Yeah. Remember what we have said. The UPC core,
Okay.
that is what informs your training.
Let me ask. Okay, I've done a diploma in counseling.
Yes, that's what I'm saying. Please look at what we have said
Yes.
in terms of look at the school guidelines, which is also available on our website, so that it informs you better what is it that are requirements for people who are going to go to schools.
Okay.
Yes. Yeah.
But
what about the community? We do not encourage. You see, community is a community-wide setting. Unajua kwa baraza, church, those are part of community. Yeah.
Yes.
But remember, when we talk of a school setting, we are talking of young, growing minds that cannot relate with the recovery story. Yeah. So that is actually what is saying. And that's why I was saying that I would like to refer you to the school guidelines. They are available on the website, so that we are able to see what exactly, we would want to.
The school I'm relating to is I'm inquiring about these tertiary educations like universities, these tertiary institutions.
And that is what I'm saying. Yeah.
Yes.
Because what exactly are you doing there? That is the question.
Yeah,
Right?
we find there are some people who are already in the habits of they're in the process of using, and also others are also addicts.
Yeah. So remember that when we talk of the structured settings like schools and colleges, yeah, there is actually a program.
Yes.
What is it that should be done with regard to that? That is what we are saying. Yeah.
Okay.
And that is why you could
thank
see even the student welfare, we were talking about who benefits from this training because they are constantly dealing with the students. All right, the next person I'm seeing is Masila Siengo. Please unmute and speak.
Thank you. My question is actually on the monitoring and evaluation that I seen presented by the previous presenter. I wanted to find out, I don't see those courses being advertised. And on the same, I also don't see any research related courses that are also inclined towards addiction research. I wanted to find out whether this is something that NACADA is looking at, or is there any other opportunity that would present itself to strengthen researchers like us who would want to get into the substance abuse research and evidence presentation. Thank you.
All right, thank you. All right, thank you. The training for monitoring is there, but you can see how far away we still are at. Yeah, we are still very far in terms of conducting. The curriculum is there, so maybe over time it is going to be offered. But in terms of research courses, I think maybe places like AMREF may be offering those courses. Yeah, because research is research. Yeah, so I can see Ashbet is agreeing with you, but remember that we are still in the formative stages, particularly with the prevention, because we are transitioning into looking at prevention as a science. But in the trainings, like for example, if you do the UPC core, there is even a section that then deals with the monitoring. Each of the programs, like for example, the life skills, it also has its own monitoring component, yeah? But there is a standalone course on monitoring, but we are not offering it right now, yeah? So it doesn't mean that it's not there, we're just not offering it now. So maybe with time, let's see how we pick up first. All right, pardon?
Would it be then if somebody is already competent in research and monitoring and evaluation, would there need then be an accreditation for which then that person is agreeable to do specific research or evaluation activities for substance abuse? That's what I was really asking. Because again, if you're talking of the same, then how then would it be able to synchronize with the already existing activities? That's what I'm asking actually, if you don't have any accreditation.
Yes. So you see the credentialing is not done just based on the monitoring alone. You will find that the basic course needs to be the UPC core. However, we can have this conversation beyond this. So maybe you can maybe just write on the training email, and then we can pick up the conversation from there, so that we respond to the other question and we see what else is the, we have a better understanding. Okay. Yeah, so we'll be able to address that. I will allow Ali Hussein. Please go ahead.
Yes, thank you very much for this opportunity, Madam Susan Maua. First of all, please allow me I will wish to put one request. I'll also want to pose two questions on the presentation related to the one that Rita has provided. But before that, for the purpose of introduction, my name is Ali. I'm an addiction professional based here in Wajir County. I was
Ali, make it short. Ali, make it short. I know you.
But my colleagues don't know me. Okay, thank you. I'll make it short.
No, make it short. So, make it short.
Even as I make short, I just want to appreciate you, Madam Susan and Dr. Londo, who took us through that. It has been a life changer, and we have really applied the knowledge. And in his absentia, I also want to appreciate Jacob Aduda. He was the one who shared our link. Having said that, Madam Susan, I want you to advise me personally, because actually as you already know, I'm a UTC I'm a UTC graduate, and I have a passion on workplace prevention. So I want you to advise me on next step I should take. That is one. Number two, I have two questions on Madam Rita. Related to her presentation. One, in a low resource setting like Wajir, where structured after school and youth programs are very limited, what low-cost community-based prevention models have shown success? Have shown success. That is the first question. Then the second question I want to ask, how can a workplace substance use prevention be adapted for public health facilities like ours? For example, I'm working in a public health facility where staff stress, stigma, and limited MHPSS are major barriers. Those are my two questions. And again, I want you to advise on my next step.
Yes, you see, if you are in a UTC that deals with treatment. So if you are thinking of workplace, then you need to do the UPC core. That will be much more helpful for you to do the UPC core, and then you can transit into the workplace. And why I'm saying this, and even if you want to start it from that end, one of the things that you need to actually have is data, data from your settings, so that it helps to address what are the issues. Because as Rita mentioned, when it comes to drug use, it's about the risk factors versus the protective factors. How do you enhance the protective factors as you reduce the risk factors? And so you need to know what these are, all right? So one of the things that you can do in the immediate is actually, is the workplace, okay? So that is, again, a conversation we can have beyond this session. And I believe part of it, we already had the other side. That's why I'm saying, I know you, Ali, make it short. Yes.
Yeah, thank you.
So,
yes. So
now, okay, with regard to adaptation, and that is what adaptation is about, addressing the local conditions. Even in the school setting, when we talk about adapting in law, remember, Kenya is already a low resource setting. It's already a low resource setting, but the skills that children require is the same. So if it is decision making, irrespective of which location they are, they require decision making. They require drug resistant skills. They require how to deal with different things like trauma and so on. So all these are, the adaptation will be, how do you relate in that kind of setting? And that is why, for example, I said life skills is ordinarily taught in a school setting, but it can still be done outside the school setting. Like, for example, if the church can organize their children, those who are in grade 5, for example, grade 5, who go to that church or whichever religious setting, or even community-based organization, you have grade 5s, depending on what program. How can you then reach those students in that setting? Because remember, they are home. So whereas the school could be doing it 1 time a week, maybe over the holidays, you can be doing it every day for a given kind of setting. All right. So that is my answer to that. And then lastly, I would want to give Eric Gishofi.
Susan, thank you very much. Yes, actually, I am really contented. And speaking on that, especially for the data, for the counties, we usually face a major gap because we don't have a way to document the people who comes to our clinics or facilities. So I was just asking very fast, how can NACADA now support counties like ours to build a basic system for capturing this data? We really don't have the data. Is there a way that you guys can assist us. Maybe is there any framework that is there? Yes.
That's why I'm saying, please write to us because we have a research unit and they are not part of this call. So I do not want to answer on their behalf. Yeah.
Okay.
So
Yes.
just write to training, and then we will link you up with the research department.
Thank you. Thank you. Thank you. Thank you very much.
Okay, so Gishovi, do you want to speak?
Hello, I was just saying that today's webinar was so informative, and thank you all for the presentation. That's all.
All right, thank you. And finally, I can see Donald Mwakabi. Your hand is up, so please go ahead. You are the last hand up. Donald Mwakabi. All right. Mwakabi, are you speaking or do we close? Let me see if there are any questions. CISA is asking if should one who has been trained as an addiction counselor with UTC still undergo UPC training? It depends on your area. Yes. So because remember, UTC, your focus is treatment. Those who are in prevention. In prevention, remember, is stopping them before they start, delaying the starting. And if they have started, they are not dependent. That is what prevention is. Treatment, you cross to the other side when now you are dealing with a person who is experiencing problems and therefore requires an intervention. So that is actually the difference, CISA. So the question is, where are you? And that is why Rita was saying it will be very difficult for you to walk those two paths. Otherwise, you may reach the center and wonder what you need to do. Okay, so I believe the answers. Thank you, Elizabeth, for also answering on recovery coach. Yes. A lot of these questions you are asking, have already been covered even in courses, and that is why I did not respond to more or less questions on the politics or the science of the drug, because here we want to focus on the science. Okay, now I don't know if Philip and Jackson Shako, you want to talk or your hands are just up. So I'm giving you a minute, Philip, if you have a question.
Yeah, thank you so much. I hope you can hear me from your end.
Yeah.
Yes. Now, I really wanted to know if you normally support county governments in terms of holding sessions that will be able to help those employees.
Mm-hmm.
What are the requirements? That is the question I had. Thank you.
Yeah, so umepotea hapo kidogo, but we have county offices, so I don't know which county you are in. Yeah.
Yeah, I'm in Taita Taveta.
Even the one there called Eric Geshovi is the one in charge of that county. But please also, you can also just write to training, yeah, in training email, yeah, so that then we are able to direct you and link you up with Eric, who is also on this call. All right. All right. So, ladies and gentlemen,
thank you so much.
Yeah, you are most welcome. And this is the conversation beginner. So please, because we have even contacted you through the training email, should you have any questions that we have not addressed, we can still be able to do that, but some of them are better addressed in the training sessions. Like what is the take home? I have said that once we have analyzed the polls, Then we will be able to prioritize which trainings are going to be done in what order. And then we will be able to share. It will be in the form of a poster. So we are going to share so that you sign up. Yeah. This recording is going to be put on our website and also on our YouTube channel. I hope the ICT people have done that so that you are able to even be able to listen or even share with others who may have wanted but did not show up here. And then what else? With the issues again of credentialing, we are also going to see based on what is also coming from the chats, what are there, so that we see how do we link up with the ICU-DDR so that we can even have a webinar for those who would like more information on that. Our aim is to professionalize prevention, treatment, and recovery so that we also eliminate quacks. Yeah. So that information, like I said, even the list of trainings is going to be posted on the website so that if this passes you by, you can still be able to read and say, when is this? But please do not wait for the training to be halfway, ndio unauliza. When are you offering this training? Thank you so much and have a blessed day, everyone. See you again later. Bye.